Oregon leads the country in advancing end-of-life planning, keeping track of what people want, recording it appropriately. And we've used the Oregon POLST Registry, first-year data, to find out how people want their care near the end of their lives. Now, POLST is for people with advanced illness and frailty. It's not for healthy people. They should have an advance directive. So for people with advanced heart disease, advanced lung disease, cancer that has spread, a POLST form makes a lot of sense. Or if you're frail, maybe you use a walker. Having a POLST form and saying the treatments you want and those you don't are the kind of thing where Oregon leads the country. And this article in Jama shows that we have at times overemphasized the question of resuscitation. Do you want CPR or not? And certainly CPR is the one thing where in a crisis, that's what we do without consent, without asking, because there is no ability to ask. We presume people want it. If you were going to do a surgery, we would ask you, we would explain it to you. But here, the assumption is it should be given. And really the only good way not to have resuscitation near the end of your life is to have a POLST form, is to have these orders in place so that emergency medical personnel in the field can respect your wishes and can focus more on your comfort and supporting your family when you're very near the end of your life, when you're not breathing and you don't have a heartbeat. What our study showed was that of those who marked "do not resuscitate," did not wish an attempt to restart their heart, the vast majority, that group, half wanted to go back to the hospital and half wanted the focus on their comfort where they were. There would have been no way to tell unless you asked. What we're finding is that for people with advanced illness and frailty, that the question about resuscitation is not the most important question. That what you would want before your heart stopped is much more important to the kind of care you'll receive and what happens, because in this group of people, resuscitation is so unlikely to succeed. It's not going to make a very big difference what happens. But if you don't say, I never want to go to the intensive care unit again, a crisis occurs, you can be put on a breathing machine, put in the intensive care unit, and you may not have wanted that. POLST allows that to be spelled out. Physician orders for life-sustaining treatment. I want certain treatments, I don't want certain treatments. The POLST program works better than traditional practices. Having a standardized way to record people's wishes allows the patient to move from one setting to another and have those wishes respected. That didn't happen consistently before the POLST program existed. And other studies of our work have shown it works better than anything anyone else has developed. So the program is catching on across the country and is endorsed in 14 states and in development in 20 more. So soon, most of the country will be using the POLST program. This paper is about the next innovation, a statewide electronic POLST registry, a place where POLST forms can be found by emergency medical personnel in a time of crisis, away from the hospital, before where you're next to your papers, your medical records. This allows a backup system to the document to assure that your wishes will be respected if you're away from your papers and out in the field at someone's home, in a garden, shopping mall, or you're at your home but you didn't have them readily available. And it allows us to look across all settings of care: nursing home, hospital, hospice program, and to see how people with advanced illness and frailty have their wishes recorded for care near the end of their lives. The Oregon POLST Registry is more successful than any of us would have expected. It has been in operation for 2 years, and we've had over 90,000 POLST forms submitted to the registry. We've had nearly 1,000 calls by emergency medical personnel in a time of crisis, and it is making a difference in the care patients receive. The overall goal was to do what the patient wanted, but what we've learned is that most people aren't saying yes to everything or no to everything. Most people want a mixture, to have some treatments and not others. And unless you ask and you record it, you would have no way of knowing that. The main finding of this study is that half of the time when people had indicated they did not wish CPR, they wanted to go back to the hospital, and half of the time they didn't. What we found was the most important question was about scope of treatment, about whether you wanted to be hospitalized, and if you did you want to go to the intensive care unit?